At the heart of today's session is a discussion on the future funding of adult social care. Many of you will know that I've been campaigning for more funding for adult social care services for quite a time. Hampshire has been under increasing pressure to support more people who need care against a funding settlement that falls short of the needs of our local population.
What I wanted to do with today's presentation is summarize some of the work we did in the One Less Social Care Review, and so talk about what is likely to, the levels of demand for social care in the future, what are the driving factors behind those levels of demand for social care support in the future, and what can be done in terms of structuring some funding arrangements in order to make sure that the resources will be there to meet that increased demand for social care. We need to decide, as I was saying, what the objectives of the system are going to be, so that we know exactly what we're trying to achieve, and therefore how much it's going to cost, who should receive services, etc. We need to come up to an agreement over how we divide the cost of these services between the state and the individual. And we need to agree what's going to happen with the local versus national issue. And we need to agree what we do in terms of better coordinating the range of support that the state is providing.
And I can tell you that I was checking yesterday, the European Parliament were equally discussing this question yesterday. A question came up on long-term care. So Hampshire, you're doing, you're doing it as well as the European Parliament. These are one of the big issues, the three big challenges to our nation, to the world actually, is terrorism and climate change and demography. And this is the bit that we've got to get to grips with.
I'm not going to restate the problem, but I think it is worth mentioning that the changing demographics are not only a challenge, but they also present a fantastic opportunity for us really to make a big difference both now and in the future. And I think it's just worth stating again some of the latest UK population projections, which show an 81% increase in the numbers of over 65s. And an even faster growth among the numbers of over 85s, which is significant because of the increased numbers of people who are likely to develop dementia. What were the GRS solutions? I think it's very important to put these into context, because if you adopted the solutions we came up with immediately, the first 4 of them would immediately, in our view, put the current system on a much fairer footing than it currently is. We are recommending higher capital limits for care home fees, and the cost of that, to raise that ceiling from £21,500 to double it, would cost per annum £270 million. We're also recommending equity release. We've got 2 suggested schemes and ways of doing this. From the Paying for Long-Term Care programme, we were talking about a student loan, so a soft loan along the lines of a student loan, which would help older people to defer costs of care until they sold the home. When I was asked to do this presentation, I was asked to spend a bit of time looking at what some of the obstacles to equity release might be. And Ken alluded to this earlier on, but currently there are 3.5 million retired households who own their own home outright. And 1 million of them have over 100,000 assets, but their incomes are so low that they qualify for means-tested benefits. So these people are, as I said, asset-rich but cash-poor, and would like to draw down very small amounts to support them to stay in their own home.
I've been in the insurance industry for about 25 years and was part of the team that launched the Commercial Union Third Age long-term care products in 1992. It was seen, because of the demographics, as an ideal opportunity for the businesses to move into long-term care and provide on a pre-funded and immediate care basis. In terms of the way forward, I just picked out a piece from our own website, which is basically, when presented with the results of the long-term care research, and this is from 2002, because there's been very little research into a market that doesn't exist since then by ourselves. 90% of over 55s believe that the public and private sectors should work together to provide long-term care. and that the right level of support would work. And I think that's really important. There have been no new products in the 21st century to assist in this marketplace. Choice is really being lost to everybody who uses it. And I think that's really something we need to think about and something for the Commission to take forward. I think the fact that Hampshire is moving this forward on its own in the way that it is really laudable.
So the first one for me is, do the sums add up? We have got a lot of unknown factors going on in part of this modernisation and this change. And at the moment, we are in a position that's already been referred to this morning, where I think pretty much every local authority up and down the country is struggling to balance its books on adult social care. So the concept of leaping into this change with a lot of unknown factors as to how you could assess them, what will be the benefit of re-ablement services? Now, they should be positive and they should actually help us, but by how much and for how long? How do we assess, and I've got it on there as well, the resource allocation? Because how we pitch that is clearly going to make a lot of difference. What are the types of the support we need? What are the changes we need to make to staffing to make it happen? All of these are unknown elements, and so to actually assess whether or not the sums add up is going to be quite a challenge in itself.
I come at personalisation generally from the perspective of wanting to nail the legal risk. And some of the things that Caroline has talked about, for instance, assessing the resource allocation, for instance, from a legal point of view, I find it laughable that local authorities think that disability lawyers are going to let them get away with putting a finite amount on a resource allocation. And that is because it is decided case law that disabled people, once they have assessed eligible needs, have an absolute enforceable right to have their needs met, regardless of the cost. Please don't take anything I say as being again personalisation. But because of my background, I come at this agenda from a rights-based perspective, and I see many aspects of it removing rights from people with disabilities and from their carers, rather than enhancing them. Now, I don't think it will be news to anyone to be told or to be reminded that government is not in favour of health service money entering into individual budgets. The co-payment principle that is in the press so much at the moment, the aggravation over co-payments, is said to be the reason why it wouldn't be appropriate to put health money, even on the basis of clinically assessed need, into a person's IB. If I turn to the question, should health monies go into the pot? Some of you may be aware that ever since direct payments have really got expanded, people have been studying what they're being spent on. And people are very overt about explaining that they are being spent on things such as injections, dressings, foot care, tissue care, bowel and bladder management, etc. And in particular, my client group, our local authorities, it bothers them because they've been persuaded to embrace the normalisation agenda, but at the same time, it's costing them money to do all of these things that would traditionally have been seen as healthcare. And here is the meaty truth. There is no line in the legal system distinguishing health from social care. And I'm afraid to say it is a line that suits any government of whatever political colour, because healthcare is paid for through central funding and local authority care, of course, is paid for through more indirect routes.